Transposition of the great arteries, the atrial switch. What's the content of the presentation? First, what's the transposition? Then the current therapy, the arterial switch. History, the role of Senning and Mustard, Blalock-Hanlon procedure and Reskin procedure. What is the essence of the atrial switch? What does the surgeon do actually? What's the end result? So what does a Senning or Mustard look like? And briefly we'll go through some late problems. The aim of this presentation is to revive the basic knowledge of the atrial switch. On the left side you see a schematic drawing of a normal heart, and on the right side a transposition of the great arteries. The aorta is connected to the right ventricle and the pulmonary artery is connected to the left ventricle. There is only one way a patient with a transposition can survive after birth. That's when there is some way to get your oxygenated blood into your aorta. And the level at which it occurs is the atrial level through the patent foramen ovale. At the left of the arterial duct, there's also an open connection between the aorta and pulmonary artery, but because the pressure in the aorta is higher postnatally than in the pulmonary artery, you get left to right shunting. Well, that's good, that's beneficial, because increased pulmonary blood flow will lead to increased pulmonary venous return, a more filling of your left atrial, a higher left atrial pressures, so a bigger pressure difference between left atrium and right atrium, and more shunting of the oxygenated blood to the right atrium, right ventricle, and the aorta. Well, transposition is quite a common cyanotic congenital heart defect, and about 5% of all patients with congenital heart defects will have a transposition of the great arteries. The clinical presentation of transposition is most often the first hours or days after birth as a blue baby. And the first thing you have to do is to assess your shunt possibility. Start prostaglandins to keep your arterial duct open and see whether your shunt at atrial level is good enough, and if necessary do a Reskin balloon atrial septostomy. After initial stabilization of the patient, the therapy will be surgical, and the surgical treatment of choice has been the arterial switch operation for the past 25 years, and it's done in the neonatal age in the first weeks after birth. Here you can see a few essentials of the arterial switch. The right lower side you see Dr. Jardine, who did this first successful operation in 1976. In the middle you see Dr. Yves Lecomte, who did the most important surgical modification of the procedure. Left upper side you see how the transposed great arteries are put back in a normal position. Right upper you see schematic drawing of the coronary arteries, very important for the surgeon during the procedure. And left lower you see the pulmonary arteries after the Lecomte maneuver with the bifurcation anterior from the ascending aorta. That was only after 1976 in most centers in the world from the beginning of the 1990s. But how was it before 1976? What was done then? First, before the era of cardiac surgery, 95% of the patients died in the first year of life. And here you can see a picture of one of the big heroes of cardiac surgery, Walton Lillehei, and he started cardiac surgery in 1955, and he operated upon ASDs and VSDs, follows pulmonary stenosis, but no transposition. There was no neonatal surgery then. It was only in the early 1960s that Dr. Auke Senning from Zurich and Dr. Bill Mustard from Toronto showed that an atrial switch was possible in children, but still only in children over 10 kilos of weight. First, you had to survive the neonatal period and the first years of life, and it was only possible when there was adequate mixing at atrial level. The surgeons Blalock and Hanlon showed that a surgical atrial septostomy was possible often with a beating heart, with an inflow occlusion, and the surgeon had to work very fast, but it was possible. And later, in 1965, the pediatric cardiologist Bill Rashkin from Philadelphia demonstrated that you could do the trick with a balloon, tearing a hole in the atrial septum, so adequate mixing could take place. And then, when the child was big enough to undergo cardiac surgery, the atrial switch could be performed by the surgeon. And what's the essence of the atrial switch? That's the rerouting of the systemic venous return towards the left atrium in such a way that the pulmonary venous return can flow unobstructed towards the right atrium. The transposition itself is left untouched. That means that the right ventricle is the systemic ventricle and the anatomic LV is the subpulmonary ventricle. This is how it looks like. A nice drawing of Hans Hamer. You see on the upper part the superior caval vein going through a tunnel towards the left atrium, and from the lower side you see the inferior caval vein through a tunnel going to the left atrium, and the posterior part of the left atrial wall where the pulmonary veins come in is unobstructed and can leave the blood flow towards the right atrium, the right ventricle, and from there to the aorta. And here again you see some nice images now from the beautiful teaching slides from the Mayo Clinic. On the left side you see a schematic drawing with the superior caval vein coming up in blue, flowing to the left towards the left atrium, the inferior caval vein and inferior tunnel also flowing to the left. And you see that the posterior part from the left atrium is left free for the pulmonary veins to drain in, flowing from there to the right atrium, posterior from the superior tunnel, and over and anterior from the inferior tunnel. In the middle you see a black blood CMR with the tunnels from the superior and the caval vein flowing to the left atrium, and right side a CMR where you see nicely that the pulmonary veins come into the posterior part of your left atrium and then drain into the right atrium. When one tries to understand the created anatomy of the atrial switch, how the atrial tunnels run, it may be helpful to know how the surgeon did it. As a surgeon, you're standing on the right side of the patient. On your left hand side is the head of the patient and superior caval vein. The left side of the patient is at the other side of the table, and your right hand is the lower body, inferior caval vein and patient's legs. You're looking down into the chest. So you're standing on the right side of the heart and looking into the heart through the opened right atrium, and you see here that a part of the interatrial septum is cut away because you can see the pulmonary veins. Indicated with the red arrow is the fabric already sutured there by the surgeon, the fabric to create the tunnels with. In the lower half of the drawing you see how these tunnels are made. The red arrow is the superior tunnel and the green arrow, the inferior tunnel, are made in such a way that the systemic venous drainage can flow towards the mitral valve, and the posterior part of the left atrium, there where the pulmonary veins drain, is left completely free, so the blood can flow towards you, towards the right atrium. And that is what you see here with the red arrow, how the pulmonary venous blood flow flows from the pulmonary veins underneath the superior tunnel and over the inferior tunnel towards the right atrium. In the Senning procedure, the interatrial septum is not cut away, but after the incision, the septal flap is used to create an anterior part of the left atrium, where the systemic veins will drain in, and a posterior part left open for the pulmonary veins. And you see on the bottom half the sausage, where the systemic venous baffle is indicated, will lead the systemic venous return towards the mitral valve, and the pulmonary venous drainage will come from the part and the lower part, the red part, flow over the systemic venous bevel towards the tricuspid valve. The principle is the same, but no fabric is used and only the patient's own tissue is used. The end result for an atrial switch, either Mussert or Senning, is very similar, and once again, the superior tunnel going to the left atrium, inferior tunnel going to the left atrium and the left ventricle, from where the pulmonary artery arises, and oxygenated blood from the pulmonary veins flow into the pulmonary venous atrium, the right atrium, and the right ventricle. And now, the pulmonary artery is still coming from the left ventricle, so the left ventricle is the low pressure subpulmonary ventricle. The aorta is coming from the right ventricle, so the right ventricle is the high pressure systemic ventricle. And the systemic venous return through the tunnels to the left atrium is anteriorly enough not to obstruct pulmonary venous drainage, so the left atrium is small. The pulmonary venous return flows underneath the superior tunnel and over the inferior tunnel towards the right atrium. The right atrium is large. Surgical treatment of transposition of the great arteries is considered one of the triumphs of cardiac surgery. From an almost certain death in the first year of life, now a big chance to survive until adulthood. But still quite a lot of patients developed problems during follow-up. Because the aorta was still coming from the right ventricle, and the right ventricle is not built to sustain systemic circulation, right ventricular dysfunction or failure can develop. And when a ventricle fails, it dilates, and tricuspid regurgitation can develop as well. Because the tunnels were created by the surgeon when the child was very young, these tunnels might become stenosed when the patients got bigger and the tunnels didn't grow that much, especially in the Mussert where fabric was used. Also during growth, the anatomic relation could change a bit and obstruction to pulmonary venous return could happen. Or when the tunnels were not 100% created perfect, or one of the suture became loose, you could get tunnel leakage. And also the left side of the heart could get problems because the high pressured right ventricle could bulge into the left ventricular outflow tract, and outflow tract obstruction could develop. And occasionally pulmonary hypertension developed in these patients. Arrhythmia is another issue. Most commonly sinus node dysfunction, probably the result of extensive atrial surgery with either direct damage to the sinus node or damage to the sinus node artery, with an ongoing loss of sinus rhythm and an ongoing need of pacemaker implantation. The good part is that AV conduction is often intact and AAA pacing is often sufficient. An atrial flutter can happen because of the many scars that are made, and you've got macro re-entries around atrial scars. Atrial fibrillation, less common, but it can happen, and it might predict or coincide with poor right ventricular function. And as last, of course, ventricular tachycardia or ventricular fibrillation and sudden death occurs. It's still open to debate who of these patients with a poor right ventricular function and VTs will need an ICD and when. All these problems do affect survival, and especially event-free survival, and you see here a paper from the Rotterdam group to be published soon with survival up to 40 years after surgery. And now the conclusion. The atrial switch is hardly performed anymore the last 25 years, but luckily there are still many patients alive after Mussert or Senning. But many patients do develop problems at adult age, and they need adequate or even optimal care. Imaging plays a crucial role, but one can only do adequate imaging if one understands the created anatomy. The aim of the presentation has been to revive the basic knowledge of the atrial switch, and I do hope it's been a bit helpful for you. Thank you very much.